Picture this. It's 2026, and you're sitting in a British A&E department at 3 in the morning. The fluorescent lights hum overhead. The air smells like disinfectant trying to mask something worse. Around you, people are lined up on trolleys in the hallway because there are no rooms left. An elderly woman has been here for 14 hours. A man with a broken arm sits next to someone who might be having a heart attack. Nobody knows when they'll be seen. This isn't a hospital anymore. This is a holding pen. And if you think this is just a bad night, a temporary crisis, a rough patch that'll smooth out with time, let me stop you right there. This is the new normal. 1 in 3 patients now waits over 12 hours on a trolley in British emergency rooms. 12 hours. That's half a day spent in limbo, wondering if the chest pain is serious, if the fever will break, if anyone is even coming. Britain isn't experiencing a healthcare delay. Britain is experiencing a transition. The country is moving from a developed world healthcare model to something else entirely. Something that looks a lot more like emergency-only triage. Something that rations care not by need, but by capacity. And here's the part that should terrify you. The NHS didn't trip. It didn't stumble into this crisis by accident. It was pushed. What you're witnessing right now is the collision of impossible mathematics and cold-blooded policy decisions made over the course of more than a decade. 5 fatal failures, each one compounding the last, each one making the system weaker, more fragile, more prone to collapse. And by the time we're done, you'll understand exactly how Britain managed to kill the very thing it claimed to love most. But first, we need to talk about the numbers, because the numbers tell a story that no politician wants you to hear. We are adding the equivalent of a major city to the British population every single year. Think about that for a second. Every year, Britain gains roughly the population of Newcastle or Southampton. New people who need doctors, who need hospital beds, who need emergency care. Now, you'd think that when you add hundreds of thousands of new users to a healthcare system, you'd also add capacity, right? You'd build more hospitals, you'd open more wards, you'd hire more staff. That would be the logical response. That would be the responsible thing to do. But Britain didn't do that. Britain did the opposite. Hospital bed capacity in the UK has actually shrunk since 2010. Let me repeat that because it sounds insane. The population went up, the demand went up, and the supply went down. You do the math on where that leaves the average patient. Spoiler alert. It leaves them on a trolley in a hallway for 12 hours. Here's the number that explains everything. The UK has only 2.4 beds per 1,000 people. Germany has 7.8. France has 5.7. Even Italy, which everyone loves to mock for bureaucratic chaos, has 3.2. Britain is running a healthcare system with half the capacity of its European neighbours while serving a population that keeps growing. This isn't a capacity challenge. This is a capacity catastrophe. And it's not like this happened overnight. This was a choice. A deliberate, calculated choice to run the system lean, to squeeze efficiency out of every square meter, to convince the public that doing more with less was somehow innovative rather than suicidal. The NHS became the healthcare equivalent of a budget airline. Pack them in, cut the extras, pray nothing goes wrong. But something always goes wrong. When you run a system at full capacity, there's no slack, there's no buffer, there's no room for error. A bad flu season becomes a crisis, a heat wave becomes a catastrophe, and a pandemic, well, we all saw what a pandemic did. The entire system nearly collapsed because there was no margin for the unexpected. But here's the thing economists won't tell you. They'll talk about efficiency metrics. They'll show you charts about bed occupancy rates and patient throughput. They'll use terms like utilization optimization, which is just a fancy way of saying, we're running this thing so hot that one more degree and the engine explodes. But they won't tell you what it feels like to be the patient in that system. They won't tell you what it's like to wait on a trolley, listening to the beeping machines, watching the clock, wondering if you're going to die before someone gets to you. The math gap isn't just a spreadsheet problem. It's a human catastrophe measured in hours of suffering, in delayed diagnoses, in preventable deaths. And it's about to get worse. Because the population isn't going to stop growing. The demand isn't going to magically decrease. And unless something changes soon, the gap between what people need and what the system can provide is going to keep widening until the whole thing snaps. Which brings us to the second failure. And this one's going to make you angry. This isn't a series of unfortunate events. This isn't bad luck or poor timing or unforeseeable circumstances. This is the result of a decade of fiscal discipline that treated healthcare as a cost to be cut rather than an investment to be protected. Let me walk you through what happened. In 2010, Britain decided it needed to get serious about the deficit. The financial crisis had hit. The government was spending more than it was taking in. Something had to give. And what gave was public health. Between 2015 and 2020, public health grants were cut by 21% in real terms. 21%, not trimmed, not adjusted, slashed. Local authorities which run most of the preventive health services, things like smoking cessation programs, sexual health clinics, addiction support, saw their budgets gutted. The logic, if you can call it that, went something like this. We can't afford to pay for prevention, so we'll focus on treatment. We'll deal with problems when they become emergencies. And at first, it almost seemed to work. The numbers looked okay on paper. Costs went down. Efficiency went up. Whitehall patted itself on the back for being fiscally responsible. But here's what they didn't account for. When you cut prevention, you don't actually save money. You just move the costs downstream. The person who would have quit smoking with help from a public health program now develops lung cancer and needs chemotherapy. The teenager who would have accessed sexual health services now has an unplanned pregnancy and needs prenatal care. The addict who would have gotten support now overdoses and needs emergency treatment. Every pound saved on prevention became £5 spent on crisis intervention. It's the healthcare equivalent of refusing to change the oil in your car because you want to save money, and then acting surprised when the engine seizes up and the repair bill is 10 times what the maintenance would have cost. But the government didn't care. They were playing a different game. They were betting they could run the NHS at 110% capacity indefinitely without a tune-up. They believed their own propaganda about efficiency. They convinced themselves that the system could handle it, that the staff would adapt, that the infrastructure would hold. They were wrong. The cracks started showing almost immediately. Wait times crept up. Staff morale dropped. Hospitals started going into the red. But instead of reversing course, instead of admitting the experiment had failed, the government doubled down. They demanded more efficiency. They set stricter targets. They told hospital administrators to make the numbers work no matter what it took. And the administrators tried. They cut corners. They deferred maintenance. They burned through staff goodwill like it was an infinite resource. But it wasn't. Nothing is infinite. And eventually the whole edifice started to crumble. The fiscal scalpel that was supposed to trim the fat ended up cutting into muscle and bone. And now, 16 years later, we're living with the consequences. The NHS isn't underfunded by accident, it's underfunded by design. It's the predictable result of treating a public good like a cost center, of prioritizing short-term savings over long-term sustainability, of sacrificing the future on the altar of austerity. And the cruelest part? The people making these decisions knew exactly what they were doing. They had the data, they had the projections, they knew that cutting prevention would increase costs down the line. They just didn't care. Because by the time the bill came due, they'd be out of office, someone else would be holding the bag, and that someone else is holding it right now. But wait, it gets worse. Because even if Britain had the money, even if the government suddenly decided to reinvest in healthcare, there's another problem. A bottleneck so severe that it's choking the entire system from the inside out. Every morning, 14,000 beds in British hospitals are filled with people who don't need to be there. They're medically fit for discharge, they've been cleared by their doctors, they're ready to go home. But they can't, because there's nowhere for them to go. This is what healthcare experts call exit block. It's a term that sounds technical and bureaucratic, but what it really means is simple. The hospital is a pipe, and the pipe is clogged at the end. Patients flow in through the emergency department. They get treated, they recover, and then they're supposed to flow out, back into the community, into care homes, into supported living arrangements. But the social care system, the network of services that's supposed to catch people on the other side, has collapsed. Between 2010 and 2020, local authority spending on adult social care dropped by £7.5 billion in real terms. £7.5 billion. Care homes closed, home care agencies cut back, support services disappeared. And all those people who would have been cared for in the community ended up stuck in hospitals instead, taking up beds that could have been used for new patients. The math is brutal. 14,000 beds blocked every single day. That's 14,000 people who could be getting emergency treatment but can't because there's literally nowhere to put them. It's like trying to fill a bathtub while the drain is clogged. Eventually, the water backs up, spills over, floods the floor. And in this case, the flood is happening in the emergency department. Ambulances arrive with new patients, but there are no beds in the wards because the wards are full of people waiting for social care. So the new patients stay in the A and E. But A and E fills up too, so the ambulances can't unload their patients, so the ambulances become stationary wards in hospital parking lots, with paramedics doing their best to provide care in the back of a vehicle while waiting for a bed to open up somewhere, anywhere inside the building. It's insane, it's dystopian, and it's happening right now, every single day, in hospitals across Britain. Here's the part that should make you furious. The government knew this would happen. When they cut social care funding, they knew it would push costs onto the NHS. They knew people would end up in hospitals instead of care homes. They knew the system would clog. But they did it anyway. Because social care is invisible. It doesn't make headlines. Nobody protests when a care home closes. Nobody marches in the streets when home care services get cut. Social care is the unglamorous, behind-the-scenes work that keeps society functioning, and it's the first thing politicians sacrifice when they need to save money. And now we're paying the price. The exit block isn't just a logistical problem. It's a moral failure. It's what happens when a society decides that the elderly and the vulnerable aren't worth investing in, that caring for people after they've left the hospital is someone else's problem, that efficiency matters more than dignity. And the truly tragic part? This is fixable. If Britain invested in social care, if it rebuilt the infrastructure that was gutted over the last decade, the exit block would ease. Beds would open up. Emergency departments would clear. Ambulances would stop acting as mobile wards. But fixing it would require admitting that the cuts were a mistake. It would require spending money, real money, on a system that doesn't generate headlines or win elections. And so far, no government has been willing to do that. Which means the pipe stays clogged, the beds stay blocked, and the patients keep waiting. But even if we solve the capacity crisis, even if we fix the funding, even if we cleared the exit block, there's still another problem. And this one might be the most dangerous of all. 34% of NHS staff report total burnout. Not stress, not fatigue. Burnout. The kind of bone-deep exhaustion that makes you question why you ever went into healthcare in the first place. Staff satisfaction is at an all-time low of 21%. 21%. That means nearly 4 out of 5 people working in the NHS are dissatisfied with their jobs. These are doctors, nurses, paramedics, the people who are supposed to save your life when you show up at 3 in the morning with chest pain. And they're miserable. Now you might think the solution is obvious. Hire more staff, pay them better, improve working conditions, and you'd be right. But here's where it gets complicated. Britain is trying to hire more staff. Medical school places have expanded. The government has made a big show of increasing the number of doctors in training. But there's a catch. They expanded the front end without expanding the back end. They created more medical school spots without creating more postgraduate jobs to put those newly qualified doctors in. So now you have a situation where UK-trained doctors, people who spent years and tens of thousands of pounds getting educated, are competing with a global pool of applicants for a limited number of junior doctor positions. It's what people in the field call the training trap. You train them, but you can't employ them. And what happens to those doctors who don't get a spot? They leave. They go to Australia, where the pay is better and the working conditions are humane. They go to Canada. They go to the private sector, where they can earn twice as much for half the stress. Britain is paying to train doctors who then flee the country to escape the very system that educated them. It's the brain drain on steroids. And it's not just doctors. Nurses are leaving in droves. Experienced staff, the people with 10, 15, 20 years of experience, are quitting because they can't take it anymore. Because they're being asked to do the impossible, to provide world-class care with third-world resources, to work double shifts because there's nobody to cover, to make life and death decisions while exhausted, underpaid, and utterly unsupported. The human cost of this is staggering. When staff burn out, patient care suffers. Mistakes happen. Diagnoses get missed. Treatments get delayed. People die. And it's not because the staff are incompetent, it's because they're human, and humans have limits. But the system doesn't care about limits. The system cares about metrics, about throughput, about hitting targets. The system is run by spreadsheet-first management that treats doctors and nurses like interchangeable units of labor, rather than skilled professionals with finite reserves of energy and compassion. And here's the truly perverse part. The harder the staff work, the worse it gets. Because when good people leave, the remaining staff have to work even harder to pick up the slack, which burns them out faster, which makes more people leave. It's a death spiral, and there's no bottom in sight. So what's the solution? Pay them more, obviously. Improve working conditions. Stop treating healthcare workers like disposable resources. But that costs money. And as we've already established, the government has spent the last decade trying to do healthcare on the cheap. Which means the staffing crisis just keeps getting worse. Which means the patients keep waiting. Which means more people die. And the cycle continues. But we're not done yet. Because even if Britain had enough beds, even if it had enough funding, even if it had enough staff, there's still one more failure. One more catastrophic problem that's been festering for years, and this one is literally falling apart. Imagine working in a hospital where the ceiling leaks when it rains, where the concrete is crumbling, where entire departments are at imminent risk of breakdown, because the infrastructure is so old, so poorly maintained, that it could fail at any moment. Now stop imagining, because that's the reality in hospitals across Britain right now. Take Stepping Hill Hospital in Greater Manchester. 13 different departments are at risk of catastrophic failure. 13. The electrical systems are outdated. The ventilation is inadequate. The building itself is falling apart. And it's not alone. Across the UK, hospitals are dealing with something called RAAC, which stands for Reinforced Autoclaved Aerated Concrete. It's a lightweight concrete that was popular in construction from the 1950s to the 1990s, and it's now reaching the end of its lifespan, which means it's crumbling, which means ceilings are at risk of collapse, which means entire wards have to be closed because they're literally unsafe to occupy. The NHS has a £13.8 billion repair backlog. 13.8 billion. That's not the cost of building new hospitals. That's just the cost of fixing the ones that already exist. Roofs, walls, electrical systems, plumbing, all the unglamorous infrastructure that keeps a hospital functioning. And it's all falling apart. Because maintenance doesn't win elections. Ribbon cuttings for new hospitals make great photo ops, but spending billions on fixing a leaky roof, that doesn't inspire voters, so the repairs get deferred, and deferred, and deferred, until the problem becomes so severe that it can't be ignored anymore. But by then, the cost has multiplied. What could have been fixed for £1 million 10 years ago now costs 10 million, and the backlog just keeps growing. Here's the sick irony. Britain isn't just short of doctors and nurses, it's running out of buildings that are safe enough to hold them. You could hire 1,000 new staff tomorrow, and they'd still be working in crumbling infrastructure with outdated equipment and dangerous conditions. The dangerous estate, as it's called in policy circles, is the final nail in the coffin. Because even if Britain solved every other problem, capacity, funding, social care, staffing, the infrastructure itself is giving out. The buildings are failing, the systems are failing, and unless someone invests serious money, real money, billions of pounds into fixing the physical plant, the entire thing is going to come crashing down. Literally. So here we are. 5 fatal failures, each one worse than the last, each one compounding the damage, each one pushing the NHS closer to the edge. The capacity crisis, the managed decline, the social care gridlock, the staffing exodus, the infrastructure decay. This isn't a broken system. This is a system that's been outgrown and underfunded into irrelevance. The NHS didn't fail because it was poorly designed. It failed because it was deliberately starved of resources while demand exploded. It failed because politicians made a calculated bet that they could run it on fumes and nobody would notice until they were out of office. And now the bill is due, and it's being paid in 12-hour waits, in cancelled surgeries, in preventable deaths, in the slow-motion collapse of what was once the pride of Britain. The diagnosis is terminal. And unless something changes, and I mean really changes, not just another round of promises and half measures, the patient isn't going to make it.